Hello, good afternoon. We are in Portugal, close to Lisbon in Estoril, at the wonderful meeting of ESH, the Lymphoma meeting 2019. And together with me are Drs. Karin Tarte from Rennes University, and Dr. Steve Schuster from Philadelphia. And my name is Michael Hallek. I'm the chairman of ESH and also the chairman of this meeting. And I'm delighted to actually have this discussion with you. So we will try to actually summarize the highlights of the meeting today, but it started already yesterday with a very good session on the role of the tumor microenvironment, which I think is of increasing relevance in lymphoid malignancies, and you gave an excellent talk, so maybe you wish to summarize what the current role is of the microenvironment for lymphoid tumors.
Yeah, for sure. So what is clear is that the role of microenvironment is increasing in this kind of tumor. There is at least two parts that should be considered. First, we have a supportive microenvironment, a tumor supportive microenvironment that is different depending on lymphoma, with as an example TFH cells in follicular lymphoma, but the role of myeloid cells also is important. And we have an anti-tumor microenvironment made up of NK cells, T cells, myeloid cells that is inhibited through a lot of mechanisms, including modulation of immune checkpoint inhibitors, but also amplification of Tregs, and this lead to the formation of a tumor supportive niche that is very important. And another thing that we discussed yesterday that is probably crucial also for CAR T cells is the role of cancer-associated fibroblasts. These cells are not only there to form an architecture, they are also regulating the recruitment, the activation of tumor cells, and they also inhibit the recruitment of T cells. And these cells are probably very important to consider when we think about cell therapy strategies.
Absolutely.
So, Karin, would you actually name, or could you name any therapeutic principle that you could envision or already know that we could use for microenvironment modulation and maybe in combination with CAR T cells? Anything that you have in mind?
For sure, there is a lot of strategy with antibodies that target PD-1 or PD-L1 or all these molecules. Yep. This is an obvious possibility, but I think that other things will come soon. Yeah. In particular, there is, as an example, antibodies that target TGF-beta that are under development. These kind of molecules will target the CAF, the cancer-associated fibroblast, and will favor the arrival of the CAR T cells inside the tumors. And also some more basic molecules like ibrutinib or molecules like that are very important, because by producing more active T cells in the patients, they produce more active CAR T cells after that, and this could be useful to treat the patients.
We're very agreeing with this, and I think we discussed it also in our session, and you gave a wonderful clinical summary of the state-of-the-art for lymphoid malignancies and CAR T cells, and also alluded to some of the possibilities to actually refine T cells. Yeah. Maybe you can sum up the highlights of including CAR T cell modifications.
Sure.
With.
I think we had a great session today, and yes. I think that the science that was presented is showing us where we're going, and I think what I presented more or less is where we are, and where we are is really at the end of the first generation of studies. So we're just beginning. And I think the science that was presented points to the future. The microenvironment, as you say, is extremely important in the success of immunotherapies in general, including CAR T cells. And this came up at the meeting. The obvious ways of manipulating the microenvironment, which tends to be inhibitory or immunosuppressive, is by doing for example, checkpoint blockade, but there's so much more to learn. For example, I can tell you from autopsy experiences in patients who have had satisfactory expansion of CAR T cells, but not a successful result, that I've seen tumors that are completely surrounded by T cells, but they're not migrating into the tumor. I'm not sure what the mechanism of inhibition is there. It's not as though there's a capsule. It's almost
blocking the entry.
And there's not a mechanical barrier that you can see under the microscope. There's not a capsule or a shell, but it just seems as though, for some reason, the cells can't get in, and that's probably one of the mechanisms of resistance. The other mechanism of resistance is T cell exhaustion. And that we do see, and particularly, I think in patients with very large tumor volumes, bulky disease, the data suggests that they do worse in terms of their outcome with regard to CAR T-cell therapy. And that may in fact be that the cells are finite and do become exhausted with chronic activation. Again, I think that's ways of reducing the tumor volume, ways of using products that are more enriched for central memory or effector memory T-cell subsets as opposed to, a more differentiated effector type T-cell subsets are some of the concepts that were put forward to overcome that. Now, with regard to ALL, B-cell lymphoblastic leukemia, there actually we had some, I thought, brilliant presentations by Andre Thomas Tokaneko. The loss of antigen by either complete blockage of the antigen going to the cell membrane or by deletion of specific portions of the antigen that are the sites to which the CAR binds are well described and well worked out. And I think another way that we can have resistance to CAR T cells. But in lymphomas, loss of antigen is not the primary thing. I think there it's microenvironment and T cell exhaustion are the primary, are most frequent. It's not to say we never see T cell exhaustion, but in these differentiated mature lymphoid malignancies, it's much less common.
You made a very nice summary, actually, where we came from and where we stand, with the increase in years of life gained or even reduction of mortality by CAR T cells as we are right now. So coming from, if I recall that correctly, in the refractory section, increasing that cure fraction of potential long-term remissions by 30%?
Yeah,
35%.
So about a third of patients who were previously untreatable with our existing therapies can achieve, with a single treatment, durable responses. And we feel great about that. It's a real breakthrough. We're saving lives of patients that in the past, we felt helpless in terms of what we could do for them. But again, I think I indicated it's a third of a rather select subset of patients, very there's 2/3 that we're not helping. So the glass is I still think it's 2/3 empty, as enthusiastic as I am about this therapy. And I think that we, like I said, these are so-called second-generation CAR cells, but we're only at the first generation of studies, and we need to move forward.
Perhaps just something.
Go ahead, yes.
Something to add. Perhaps it has been discussed also this morning is the capacity to engineer CAR T cells in order to activate all the cells of the microenvironment, including innate immune cells. I think this is very, very interesting, and the capacity of CAR T to bring to the tumor a drug that is perhaps toxic if we administer it by intravenous infusion, but if you put it inside the CAR T, you can bring it to the tumors. I think this is.
For example, the trucks that were presented today, CAR T cells that are designed so that they can secrete locally cytokines which are toxic when given systemically, like interleukin 12. So they can deliver high levels of these cytokines to the tumor sites and overcome systemic toxicity, enhance the response to the CAR T cells. And I think some of the work that was shown was just fabulous, like with the mouse models with the the 2 implants of tumor and seeing responses on both sites, even though the infiltration was primarily.
It was so just some learning of the immune system, basically, against specific antigens.
Yeah.
So that was fascinating. So in other words, I think we are overall standing at the very beginning of a totally new era of medicine, like engineered cells.
Yes.
That are acting against tumors, and we'll see I think, much more of it.
Yeah.
And hopefully more curative treatment.
Yeah, and lots of ways to get these cells to be more effective, not just by engineering the cells, which is obvious, and they discussed off-the-shelf CARs and et cetera, but even small molecule therapeutics that can enhance T cell activity. Ibrutinib was discussed. I actually think that we will see that we can even use bispecifics with CARs to get multiple antigen targeting, things like that. There's so many things to do.
So we have to summarize also, for me that was the highlight of today, the CAR T cell session with it was a really comprehensive overview. I think we got exactly taught by you and others where we stand right now, and also the problems that we have to overcome. And it was realistic and extremely good from a clinical side, from a realistic perspective. Now the afternoon covered a little more the novel agents, the small molecules, not the cellular therapies, and then applications in the last session on CLL, mantle cell lymphoma, DLBCL, follicular lymphoma, and central nervous system lymphoma. And I think we can probably summarize it in a bit more general way, because we would say the highlights of this are, I think there is some hope with novel agents. In particular, we all hope that the novel BTK inhibitors might be a little less toxic and even a little less efficient. So we will see the randomized comparisons. There's all kinds of BTK inhibitors coming now, and we hope that we can reduce a bit of the cardiotoxicity for these agents. I think the most intriguing results of the last 2 years is BCL2 inhibitors, venetoclax, alone, but in particular in combination with ibrutinib, with obinutuzumab, that's working in many lymphoma. The best efficacy that I've seen today, but also in general, is in CLL, where it's becoming standard first-line therapy now, venetoclax plus obinutuzumab. Data have been shown by Stefan Stilgenbauer and Barbara Eichhorst, but also venetoclax plus ibrutinib. There's preliminary data both in CLL, but also in mantle cell lymphoma. So the big thing is there's two entities, and you would agree, I see you nodding, that venetoclax plus ibrutinib or plus obinutuzumab is also a very active principle in mantle cell lymphoma.
Absolutely.
So that we might actually be able to bridge in those refractory mantle cell lymphoma with these combinations, or even have some potentially curative results. Simon Rule was saying this afternoon that he even sees efficacy in mantle cell lymphoma that have a p53 mutation, so the high-risk mantle cell lymphoma. So he gets MRD negative remissions in mantle cell lymphoma, the same thing we're seeing in CLL. So somehow, all of a sudden, two formerly totally unrelated entities, mantle cell lymphoma, poor prognosis, CLL, rather better prognosis, one thought, are behaving very similar in terms of these novel agents.
I think one important point that emerged from the discussions was that those things that were negative prognostic factors in the era of chemotherapy are almost irrelevant in the era of these agents that act by different mechanisms. And things like p53 may be very important in mediating the DNA damage response induced by chemotherapy, but not very important when you interrupt B-cell receptor signaling or threshold for apoptosis with BCL2 inhibition, or immunotherapies, external targets. And I think you're exactly right. The combination of anti-CD20 antibodies and venetoclax is incredibly impressive in poor prognosis CLL and CLL in general. It raises the question, should it be first therapy? And many of us feel it should be.
We think it will be.
But we do have a trial last year that showed a prolongation in overall survival for patients that received BTK inhibition. Ibrutinib is first therapy, part of first therapy, with or without an anti-CD20. So when you have a study that shows an improvement in survival, to make the leap that there should be another first therapy, even though you know that you feel, based on the data, that it's coming, is a hard thing in practice to do.
Yeah, we think, because that's one of the trials that we have been following, and also do trials again. We will actually test this formally We are not convinced that this survival benefit is real because it's depending on very few events. And the events in the FCR arm increasing. There's a 2-to-1 randomization, and that is always very, very sensitive to small numbers of events. And there were a high number of CLL-related deaths, so therefore the story is not told. The last analysis, the overall survival curves actually approached one another already. So I do not think the story is already fully told and needs to be followed. But the big question in CLL first line is, as you rightly say, is a monotherapy over a long time, 5 or even infinite therapy better or equally potent as a short 1 year finite therapy with venetoclax or obinutuzumab? That's going to be the next big question in CLL. CLL 17 protocol will be starting next year.
And I guess another question that we will find out the answer to, although one can only speculate at this point, is when we start using as first therapy, for example, venetoclax, with or without an CD20 antibody, we don't yet know in those patients that progress or fail after that form of therapy whether you can go back and get the same kind of results with BTK inhibition or...
absolutely right. But the
sequencing.
Correct. But the key thing here is we do not want to have any sequencing anymore. We want to have cure. So the MRD negative rate with venetoclax plus obinutuzumab is at around 75% in a randomized protocol, which means that approximately, from former analysis, we know that 60% of those may be cured, or may have long-lasting remissions. That's data we know from FCR. So there's 2 different mindsets, if you will. So you go for the good first shot and then cure the disease. Or you have to go for subsequent therapies, and in CLL everything is aimed at cure by the initial treatment. Right now.
So what would you say now, Michael, in practice? You have a patient who has been on ibrutinib for 2 or 3 years, has had a very good response, the blood count is normalized, but there's still residual disease at this point. Would you take that patient and switch their therapy?
It depends on the molecular risk of this patient. So if you have a low-risk lesions, like let's call it a deletion 13q, just to take an example. 13q is having a good prognosis. You could carry on. Usually, if there is no side effects, if there is a deletion 17p, p53 mutation complex karyotype, I would do everything to get this patient into MRD negative remission, because I would be afraid that one day Richter's transformation will occur. So now we have actually dig deep into a very specific question on CLL management. Maybe we go back and summarize a little bit. And I have to admit, in the other areas, DLBCL, follicular lymphoma, CNS lymphoma, the news at this meeting was not to the same extent. There's a couple of new agents, but they need to be tested. Lorison had to admit that we are still not having any progress for over R-CHOP, whether it's by combination or maintenance. She showed all the different trials, and basically they are all negative. So basically, a little bit, I wouldn't say call it frustration, but there's nothing that emerges as a new pattern. CAR T cells, of course.
Jeremy Abramson's presentation with using CAR T cells, albeit in a small number of patients, I thought was very impressive.
Absolutely.
And gives me hope that may be an approach that is useful.
And perhaps just concerning inhibitors, something that we should keep in mind is that we always consider them for their action on the B cells, the malignant cells, but they have also an impact on the microenvironment for sure, both the immune microenvironments, also probably the cancer-associated fibroblast. And just to keep in mind that yesterday we have a very rapid presentation of Ari Melnik, where he showed that when he modified EZH2 in his mice model, it strongly impacts the crossover between the B cells and the microenvironment. Yeah, so all these molecules have very impressive effect on the B cells, but when we are using them, we should consider how it will impact the rest of the microenvironment, and so how then it will impact the second, the third line, including immunotherapy, including CAR T cells and so on.
Absolutely.
And also the normal components of the immune system outside the microenvironment. The activity looks very good in the malignant B cells for epigenetic therapy in follicular lymphoma, but at the same time, you're paralyzing T cells. Yeah. So how can you get around that? Well, I mean, we did a study some years ago with Carl June that we had still haven't published, but where we took T cells from patients by pheresis, peripheral blood, mononuclear cells, expanded the T cells ex vivo, ablated the immune systems using fludarabine cytoxin, and then gave them their T cells back. So these T cells were outside of the body while we were giving this cytotoxic therapy that would have destroyed the immune system, gave the immune system back. It was a small study of 16 patients. Half of those that were refractory follicular lymphoma and rituximab refractory as well. And half of those patients are still in remission now at beyond 16 years.
Amazing.
Yeah. So if one can conceive of keeping the T cells safe while you're using your HDAC, to prime the B cells, make them expose antigens, and then come in with T cells that are not exposed, it may be an approach. There's just, the concepts that are emerging just almost give you unlimited ideas in terms of what to do next.
And both of us would probably say the role of the microenvironment is just at the beginning to be understood.
Yeah.
And we will explore that much more. Many of those agents, including the kinase inhibitors, act in this compartment, and they have some of their effects there. I would like to conclude with one example, and we can all have a final remark actually after that. MCL1 inhibitors. So one of the key mechanisms of resistance is obviously in B-cell malignancies MCL1, and we all hope that these MCL1 inhibitors someday will get into clinical trials. It seems that the current inhibitors have been halted in a clinical trial that was just opened, but there was toxicity, relevant toxicity, so therefore we don't know. But Andreas Strassel from Melbourne actually showed again how potent those MCL1 inhibitors might become in overcoming resistance to venetoclax, being active also in patients with poor risk. But he also showed elegantly that with an MCL1 inhibitor you also get resistance in P53 mutated patients. So very, very careful work, and I think but that's one of the classes of agents that I hope that they will enter the clinic fairly soon.
We all recall how many BCL2 inhibitors didn't make it. One almost did, but there was thrombocytopenia and finally venetoclax. But so I think they'll get there.
Maybe you conclude with either your personal highlight or your impression of the meeting, whatever you think. I
think this meeting is spectacular. The ESH meetings in general are very rich in the scientific rationale for the clinical developments. And I think as you hear the people that are doing the work present their ideas and their work, it just gives you an insight into where we're headed and what the potential is for the future.
Makes us think, right?
Yeah. I fully agree with you. And something perhaps I would like to add, yesterday Jude Fitzgibbon told us that it's very important in all the clinical trials to keep the samples in order to be able to analyze, as an example, new genetic alteration and so on. And I think it's exactly the same for the microenvironment. So for all the trials we are performing with the new inhibitors, with the Tarte and so on, we need really to get all the materials to be able to come back to understand really what happened in order to design better clinical trials for the future.
And the early CAR T trials that we did, we're still analyzing biopsies and blood samples from patients, and those trials began 6 years ago. So there's lots of work to be done, lots to learn.
My personal conclusion is from this meeting and from this interview actually, I think that in the audience everybody can see that we are excited to be able to work at this time on lymphoma, and we hope that our work makes relevant progress to our patients. So I think that is something that everybody can feel. Thank you for this conversation, and thank you also for being here in Lisbon or Estoril.
It's a pleasure.
Thank you.